Starting our next session immediately. So the chairman of this session is myself, Dr. Kashyap, and co-chairman is Dr. Maiti, Dr. Ranjan Gupta. The moderator is Dr. Anaga, and the judges are Dr. Manisha, Dr. Nilesh, Dr. Prashant Agnihotri, Dr. Chandrashri Ratra, and Bhavna Sharma. So without any delay, I think we will start the first paper by Dr. Ganesh. I hope you all know about these the ifs and buts, and you have to be on time. We are giving you marks on novelty and practical applications, the social and clinical impact, the cost efficiency, and the potential commercial viability. And for everything, you'll be getting 20 marks each. If you are late, your marks will be deducted. So be on time, be precise, specific, and prove your point. Thank you. So let's start the first paper. Dr. Ganesh, are you there?
The presenters should load their presentation, and we shouldn't delay in starting the show. Ganesh is here. Who is the next one? Jitendra? Yes, sir. Yeah, Jitendra is there. Yes. See, we will not wait for the... Over to you.
Can you load the presentation, please?
And you have 4 minutes time.
Yeah. Please load my presentation. So my presentation is about doing most of our ROP screening work on mobile. So it's basically an app which we have designed. We all know that, So when we do ROP screening, we know that there are two major important points. One is to predict whether there is a disease and whether we can prevent and whether it needs a treatment or not. And the second part is the medical legal aspect of it. We all know that most of the cases nowadays in Western countries are for ROP not detected properly. So I think record keeping is one of the most important parts of the entire process. When was baby referred, whether baby was seen by the ophthalmologist or not, what was he advised, was he diagnosed correctly, what was the treatment part, what were the complications of the treatment. So basically the stakeholders in ROP screening are ROP specialists, that is us, ophthalmologists, neonatologists, and of course the parents, because it is their kids. So they also are interested into what is going on in these kids. So this is a simple solution where once you get started, there are 3 things on the front screen. We click the ROP specialist, put our mobile number or login password, and we get entry into it. Now this is where it gets interesting. You have a screen where you have seen patients, unseen patients, and new patients. New patients are patients which are loaded by neonatologists on your screen. So they will put up all the details about the patient, what was the date of birth, expected date of delivery. So before you go to screen in the NICUs, you already know what is going on there. And once you screen them, there will be a screen where you can upload the picture, if it is a picture-based or a fundus camera-based screening, or if it is a manual screening, you can put up your own, whatever is your diagnosis. So this is the patient, this is who has referred, this is the consultation part. You can change zones, you can change the picture, you can change what is the treatment. So essentially, it is bringing everything on the mobile for the ROP specialist because it becomes easy for him. And the next part is, next stakeholder is neonatologist. Now often what happens is whatever we are doing, they are not aware of that. So I am going to 5 NICUs and I have 5 neonatologists which are with me. Now all these neonatologists are at a different point, and sometimes I also don't remember what happened with baby of Rupa or baby of Kamini. So they can themselves see on their screen what are their patients which they have they have put the data inside. They can get the reports, they can see whether the patient has already been seen or it has been missed by the staff, patient was not dilated. And then finally the last stakeholder is parents. Of course, parents are the most important stakeholders because they are the ones who want to know what has happened to the kid. So they don't have a login. They only have a login with their mobile number, and they will get an OTP and they will log into it. So there is no mismanagement between which patient was seen and they can get a report of another patient, because it is purely based on their mobile number. So they, they cannot change anything. They just can download the report. They can talk about it, what has happened, and they have different screens where you can counsel them. There are videos in this. You can put up your own ROP video, what you are talking about, and you can give more information in local language also. You can talk about it. And finally, what is new in this? So when I started looking at my ROP practice, I could not get a single EMR or a single solution where I can easily do my ROP practice and give them information and easily do it. Lot of times I used to miss out on patients. I used to go to NICU. They were saying that there are 4 patients and I saw 3 patients. I came back, I have to again rush. So this will make life simple for me. For neonatologists, it will make it more transparent. At the fingertip, I have all the records of the patients. So that's all from my side. Thank you. Yes.
It's a very interactive type of app we have developed. How do you know, filter the information? Because this information, if it is available to a person who doesn't understand the disease, would have a lot of issues in this.
No. So there are different, so once you go inside the app, there are 3 different, what we have done is there are 3 separations. One is the ROP specialist. So that is me or you, and you will click on it, you will have a separate page, and then you will be linked with all the neonatologists that you can find out.
So
like
there is a firewall between these.
Yes, of course.
Very important, because
Very
that's,
important.
if there is mixing,
Data is,
it will create a lot of confusion in
it
the
will
minds
create
of
a havoc, because intermingling
if
of
you-
data will create total, it will become even more worse than what we are currently in.
Any other questions if you have?
Yes, ma'am.
I have one question.
Morning.
This app which is there for the neonatologist, will it tell them which baby to send for screening, or how
No,
will
no,
that
no, no.
help him?
So there will be guideline. So on their screen there are guidelines. We have put up ICROP 3 classification, but it is variable. So whoever downloads as a ROP specialist, you have access to their screen. You can put up data, new articles, whether like propranolol can be used for plus disease. You can put up new data for them. You can put up new information. But in no way we tell them which babies to. There are obviously guidelines are available, but they have to put up, or their staff has to put up the patient and patient's profile, patient's data and everything. Once they finalize that baby, only then it will reflect in your screen that this is a new patient.
Jitendra, great job.
Thank you, sir.
Can
Thank
you come and collect your certificate?
Yes, sir.
Do we have Ganesh here? He's not there. The next speaker is Dr. Janardhan Bhaskaran. He's here. Jay Prakash. Jay Prakash. Sorry.
Good morning. So 30 years into phacoemulsification. One day I was left in the lodge, it is not moving. Yeah. After doing my rexis and hydrodissection delineation, I found that the phaco handpiece was not working, and that was my standby phaco machine. So how to proceed to remove this nucleus? I used these simple instruments available with us, a 26 gauge needle bent at the hub with the bevel facing to one side, a blunt chopper, cartridge with an injector. Go in and do my bimanual IA, take off the cortex and the epinucleus from the anterior surface, hook the equator of the nucleus, and then go with that 26 gauge needle and get a neat chop. Turn it 90 degrees, and then once again hook the equator, get the next chop. Rotate and divide it into 4 quadrants. One quadrant is nudged into the anterior chamber. The cartridge is introduced into the anterior chamber at the pupillary level. With a Sinski's hook, you stuff the nucleus into the cartridge tip so that most of the nucleus goes into the tip. Loose, powdery nuclear material remains in the anterior chamber, which is visco-expressed. once again, the next quadrant, go in with your cartridge, use your left-hand instrument, stuff it into the cartridge, take it out, and then do visco expression of the residual cortex and the nuclear material. These finer materials come out very easily, and when it comes to the last piece, once again, the same thing is done, no damage to the endothelium, no damage to the PC, and the epinucleus is visco expressed. Bimanual IA of the cortex, you can use your Simcoe. Then you go in and implant the lens under continuous irrigation through the 2.8 mm incision, dialed into position, OVD removed, moxifloxacin injected, the wounds are hydrated. 5.5% was my endothelial cell loss count, much better than phaco. This procedure of cartridge-assisted cataract surgery can also be used when you do your phaco and you end up with a PC rent. Inject a dispersive OVD behind the nuclear material, covering the PC rent. You go in with your cartridge, bring that nuclear bit to the anterior chamber, push it in, stuff it into the cartridge, and take it out. This goes on very smoothly. There is no fear of dropping the nucleus down back into the vitreous. You have one small bit remaining, go back again, gently, take your time and put it in, then go in with your vitrector, do a nice vitrectomy, get a 3-piece IOL into the sulcus and get an optic capture. So here, when you have a PC run, there is no need to continue using phaco with the risk of dropping the nuclear bit. There is no need to scaffold. There is no need to put in a new scleral tunnel incision. So hence, dear friends, here I present cartridge-assisted cataract surgery as a primary procedure for cataract surgery through a 2.8 mm incision with no phacoemulsification, no femtolaser for nucleus up to grade 4. It can also be used, remember, it can also be used when you have a phacoemulsification with a PC rent.
So please, your time is.
Thank you so much. You can use your SICS nucleus to learn this technique in vitro. Thank you so much.
Professor, you know, have you ever done studies about endothelial cell loss?
That is what I showed, sir.
No, but then you are saying it is better than the phaco?
It is definitely better than phaco in my hands.
I would.
Because of the 3 reasons. There is no energy spent in the anterior chamber. 1, 2, there is no continuous flow of fluid in the anterior chamber. 2. For these 2 reasons, the endothelial count will be much better than phacoemulsification.
Okay, but you don't have any study comparing the 2?
I have studied because in my hands it's about 8% for phacoemulsification. 8% endothelial cell loss for my phacoemulsification.
No, but this, but the video which you showed, there was a lot of manipulation of the nucleus, divided nucleus, and
that happens at the
into
pupillary plane. That
cartridge.
happens at the pupillary plane, and the nucleus is just nudged into the tip. It easily goes into the tip because it's a 2.8 mm. It's a large bore cartridge.
Thank you so much.
One more question.
Is
One
it
more question.
possible with grade 4? I think it's very difficult for grade 4.
Yeah, grade 4.
Impossible, I would say, yeah.
It is possible, but it takes slightly more time. The average time for me now is 14 minutes, but for a grade 4, it takes at least 25 minutes.
After putting the nucleus in the cartridge, what do you suck it?
No, I take out the cartridge.
How do you take out the cartridge? Because
No, it
you
is
have
in the handle, right?
right.
So I take out the handle and we co-express the residual nuclear material. What now I am working on, I'm working with Dr. Kakadia on getting a small flow machine to be attached to this cartridge so that once the nuclear material is inside the cartridge, it can simply be slowly sucked out without an AC loss.
Because the moment you suck it, there is chances of AC collapse. Anyway, thank you very much.
There's no chance of AC prolapse here because we are continuously, the cartridge is filled with OVD initially itself, so that once you stuff, that is being simply replaced. So the AC remains stable, absolutely stable.
But you use the word visco expression, that's why. Yeah.
What gauge of needles you are using for grade 2 and grade 4? Are they different?
No, it's only 26 gauge needle. It
Very
divides very well. For all my phacoemulsifications, I do a pre-chop with my 26 gauge needle.
Very innovative, very innovative.
Thank you so much.
Dr. Narendra Singh, are you there?
Jayaprakash, please collect your certificate.
Yeah.
The
morning.
toric error.
All the judges, I will show a video of 4 minutes. The formula which is better than estimated.com, and it is having some advantage on the Barrett RX formula for toric lens misalignment. You can
Great.
see this.
Your time starts now.
Yeah, start the video.
Analyzer is an advanced realignment formula with new features. In this case, a T9 multifocal toric lens was implanted with post-op refractive surprise of 6 diopter. According to astigmatismfix.com, realignment would result in residual refraction exceeding 1.5 diopters, making an IOL exchange a more suitable option. In contrast, the Barrett RX formula suggests that realignment is the best option. Why are the results so different? And which formula is more accurate? This discrepancy arises because, in astigmatismfix.com, the power of the toric lens at the corneal plane is fixed based on the toricity ratio, whereas in the Barrett RX formula, it is variable based on the ELP, making it more accurate. Astigmatismfix.com requires only 2 input parameters, which makes it easy to use. However, the Barrett RX formula requires several additional inputs. We developed a new mathematical formula, the toric error analyzer, which provides realignment axis and residual refraction as accurately as the Barrett RX formula, while being easier to use than astigmatismfix.com. These are the 4 factors responsible for refractive surprise. Misalignment of the toric lens. SIA, error in PCA, which is the difference between the preoperative PCA value used in the toric calculator and the postoperative PCA value. Inaccurate toric lens power recommended by the toric calculator. The toric error analyzer is the first of its kind to calculate the refractive surprise caused by these 4 factors separately and display the results in the form of a graph. Here is an example. This is a case of against the rule astigmatism plus 0.37 diopter at 170 degrees. The recommended toric IOL was plus 21 diopter T2 at 176 degrees. Plus 22 diopter T3 IOL was implanted at 176 degrees. Postoperative refraction was plus 0.25 diopter at 56 degrees. Both realignment formulas recommended rotating the IOL from 176 degrees to 3 degrees to achieve emetropia, and toric power of the exchange IOL increased from T2 to T3. Currently, toric error analyzer is only method to determine why axis rotation of 7 degrees occur and why the toric power increases from T2 to T3. It can be accessed on both Android and iPhone devices. Enter this URL or scan QR code. Click on toric error analyzer. This data sheet will open. Enter the postoperative refraction, toric lens power, and its current axis, and the analyzer will provide the best realignment axis and residual refraction based on the fixed toricity ratio, which is identical to the results from astigmatismfix.com. Next, enter the axial length, ACD, and A constant. These results are calculated based on ELP, similar to the Barrett RX formula. Finally, enter preoperative and postoperative keratometry, net astigmatism, or TK. The analyzer will provide the amount of refractive surprise induced or corrected by SIA and errors in PCA. It also provides the preoperative and postoperative power of the toric IOL. The toric error analyzer also provides a conclusion. In this case, rotating the lens from 176 degrees to 3 degrees will decrease the residual refraction from 0.25 diopters to 0.1 diopter. The preoperative power of the IOL was 1.17 diopters, which is close to T2. This increased to 1.34 diopters, which is closer to T3. The preoperative axis of alignment was 176 degrees, which was rotated 7 degrees counterclockwise, 5 degrees due to SIA, and 2 degrees due to an error in PCA. The new axis of alignment is 3 degrees. Thank you for your time.
Any comments on the...
I often surprise why do you have to find mistakes and everything in yourself only? Why did you think that there could be
Toric error
some
analyzer.
problem in the company and there might be some mistake in the IL also? Many times you do all the calculations and find that the patient is having is accepting -5 diopter is spherical, and with no rhyme or reasons. So they are also at fault. So we have to check those factors also.
Actually,
A nice presentation.
the main aim is that when we having misalignment, So what we are doing, we are going to estimatefish.com. We have to enter many data. And when the eye is long and when the eye ACD is large, after misalignment, the recommendation that you should rotate the lens is different from the Barrett RX and the estimatefish.com. They are giving different result. And then you have to go to a Barrett RX also. So in our formula, you will access both together. So you have to enter only 6 data, you will get the result as estimatefish.com will give identical to that, because we are using same formula. Then enter 3 more data, then we will calculate the ELP, then we will give you the toric power as the Barrett RX is given. Additionally, we will also tell you that what happened in this case. Previously, Barrett toric calculator was telling that you have to implant T2 lens, and in 176 degree. Doctor has implanted T2 Alcon IQ in 176 degree. Still, after implantation, Barrett RX was saying that you have to rotate it. Why to rotate it? Why? What was the factor which caused rotation? Our analysis will tell it that SIA has caused this rotation and error in PCA. So if there is some surprise, you get some surprise. So at least you can find out why I got the surprise. Otherwise, you will lose the confidence. Sometimes this happens in your measured PCA, measured TK. The instrument might not be measuring the posterior cornea astigmatism properly. So every time you are getting some error. So at that time you will get that this error is due to the error in PCA. So that whether I should use predicted value, measured value. So this is the additional thing which this calculator is providing. No other calculator are having these features.
Yeah, it's all the more good reasons to keep your data with you, pre-operative and post-operative. You should take all those data. Thank you so much. Very nice presentation.
Please collect the certificate, please. Next. Dr. Ishani? Do I see Dr. Ishani here? No. Oish. You're there? Yeah. Are you ready with your presentation? Yeah. Dr. Ganesh, he's here. This is the last call for Dr. Ganesh. If he's not there, we'll drop his name. Yes, Ishani, all yours.
So good morning everyone. I am Dr. Ishani, PG resident at Hamdard Institute of Medical Sciences and Research. My motivation starts from a daily scenario that we see in the hospital of taking out the blood samples in an ICU settings or accidental areas where it is very difficult to take out blood samples from patients. So daily pricking is very cumbersome for the patient also, and there is no such technique that we have established as of yet where we can see a non-invasive technique for accurate blood estimation. So there was a finding that I had seen in OPD. This was a blood cell that was flowing through blood vessel in a conjunctival blood vessel. There are several videos that are supporting this factor. So this is not merely an incidental finding, but rather we can see we have supporting papers for non-invasive techniques, the transdermal optical imaging, the functional near-infrared spectroscopy, or the photoplethysmography, the Fitbit or smartwatches that we see. However, these are not as accurate as the invasive technique, and nothing can supersede the invasive techniques. So there was a supporting paper that was given by Joe H.C. et al. In 2021, where he said that the range of conjunctival blood flow velocity is 0.078 to 0.0338 millimeter per second in a healthy adult, and he calculated the average bulbar conjunctival vessel diameter to be around 10 microns. So the principle behind my innovative idea is, in a given area of blood column, by assessing the velocity of cells, we can evaluate the flow per unit time area. Flow per unit time area will be equal to the velocity into area of cross section. According to Joe H.C. et al., it will be around 78.5 into 10 to the power minus 12 meter squares, and this result will be compared to the invasive technique and calibrated accordingly, which will give us the increasing or the decreasing trend. So my study design will be healthy adults 20 to 50 years of age with nil systemic illness, it will be an experimental study and will require ultrasound Doppler probe which is tunable to 20 to 50 megahertz, a portable ultrasound machine and a fast Fourier transform. So we'll use the same procedure for A scan that we are using. However, instead of using the cornea, we'll be touching the conjunctival blood vessel. And instead of 8 to 10 megahertz that we are using in A scan, we'll be using 20 to 50 megahertz. This will be a novel technique and a feasible one. We are in the conceptualization phase. We haven't experimented yet. I'll require the know-how and the expert opinion of our faculty for the same for this. Thank you.
Very innovative idea, but there'll be a lot of difference because the child, especially the child, the eye conditions are not all the same. You know, you intend to open the eye, the patient tries to close the eye, then there will be a little bit of congestion, there will be change of flow of the blood in different positions in different times of the day. You know, it'll vary quite a bit.
Next, thank you so much. Please collect your certificate, Dr. Ishani. The next speaker is Dr. Atul Sonamne. Yeah, you're there. Please speak to the mic, please, because you're sound.
Yeah.
I finally acted this year to design a new eyelid speculum, which tries to overcome the problems associated with current eyelid speculums. I would like to present a new eyelid speculum design for intraocular surgeries, which provides adequate exposure of the surgical field without causing intraocular pressure rise by pressure on the globe, and also avoids damaging the levator palpebrae superioris. We encounter a few problems during the use of existing eye speculums, including inadequate exposure, especially with the Baraka eye speculum, pain during eyelid retraction when operating under topical anesthesia, and an increase in intraocular pressure in the range of 5 to 10 millimeters of mercury in the case of eyes with a shallow orbit or large eyeball due to pressure on the globe by the speculum. Post-operative ptosis occurs in eyes with a small palpebral fissure due to levator palpebrae superioris damage by the eye speculum. Routinely used eye speculums at present include the Baraka eye speculum, which is lightweight but provides inadequate exposure many times. Liberman's eye speculum, which provides adequate eye exposure but presses on the temporal side of the globe in eyes with shallow orbits or large globes. And Cook's eye speculum, which does not exert pressure on the globe but provides inadequate exposure by retracting only the central part of the lid with its small blade length, while the medial and lateral parts hang sideways, narrowing the surgical field. In a eureka moment, I realized that current eyelid speculums separate both eyelids simultaneously, leading to the issues we face daily. If both the eyelids are retracted separately using two individual superior and inferior eyelid retractors, we can overcome these issues. During routine electric work in the house, I had observed that the copper wire used by electricians is very malleable and can be bent easily into the desired shape. So, I purchased an 18-gauge copper wire from the local electrical shop, and by following these steps, bent the wire into the desired shape and made my first eye speculum for retraction of the individual eyelid. This is the new improvised design, which I am currently using. This is a short video of the speculum in actual use during manual small incision cataract surgery. I am happy. been able to achieve my goals of adequate field exposure, avoiding intraocular pressure rise, and preventing levator palpebrae superioris damage. Thank you.
Very good presentation and very well thought. But these, when you give the brittle sutures like that, in this time also, while you making the thread into the speculum, these threads also might get the loosened. So you may lose the effect of the speculum and opening the eyes.
Yeah, that I have observed. I have to retie the bridal suture to the drape during the surgery 2 to 3 times to maintain the tension. Means to get the adequate exposure. If the bridal thread grip is loosened from the artery grip, then the speculum, the lead goes upwards or downwards towards the center. Yeah.
Atul, have you ever controlled like from the nasal bridge, if suppose you're using instead of from the temporal side,
Yeah.
if you're using the same retractor from the nasal side with the self-retention, it works wonderfully and you don't have to worry about it because nasal field is out of your
Yeah,
surgical
I have,
area.
I have seen some videos of
Because for
doctor.
my all LASIK patients, we always have a nasal speculum, nasal side.
Yeah, only problem is if there is a large eyeball or a short orbit, any speculum presses on the eyeball.
That you may need to have
Yeah.
one or more than one speculum, but
Yeah.
then you decide which speculum suits a patient. Because
Yes.
you cannot have all the nasal bridge equal for every case.
Yeah,
Anyway,
but-
that's my 2 bits.
Yeah,
Thank you so much. It was wonderful. Please collect your certificate.
thank you.
The next speaker is Dr. Bhavesh Chandra Saha. Is he here? Yeah, please come. Why don't you come and Bhavna, welcome. Where were you?
Good morning, everyone. I'm going to present as it is a video presentation for this one. Good morning, everyone. I'm going to present my innovation. It is a video presentation about the identification of Schlemm canal in while doing trabeculectomy in congenital glaucoma. Video, please.
In conventional trabeculotomy, accurate localization of Schlemm canal is the key to successful surgery in case of congenital glaucoma. Primary congenital glaucoma with an horizontal corneal diameter less than 13 millimeters. The axial length is less than 23 millimeters. The anatomic abnormality of Schlemm's canal is usually not significant, facilitating its easy identification during the operation. In large ophthalmic eye there is abnormally stretched limbal anatomy makes it difficult to identify the Schlemm canal or may not be found in 1/3 of case at all. Tips to identify the Schlemm canal is blue-white junction at surgical limbus, presence of perforated vessels and slight depression over Schlemm's canal. After incising anterior wall of Schlemm's canal by radial incision, insertion of Hum's trabeculotome in Schlemm canal that may lead to inadvertent entry of trabeculotome into anterior chamber, especially in very large eye having stretch limbus. Nowadays microilluminated catheter is being used for correct identification of Schlemm canal tract and also for doing 360-degree trabeculotomy. But due to high cost and non-availability of microcatheter in India, we are using 25-gauge light pipe to identify the right tract of Schlemm canal. This is the uncovered tip of 25-gauge light pipe. 25-gauge light pipe is easily available as it is used by vitreoretina surgeon for pars plana vitrectomy. incision is being given in the area of blue-white junction and perforated vessels. After incising anterior wall of Schlemm canal, and by seeing the area of slight oozing of aqueous, 25 gauge light pipe is being introduced to know the right tract of Schlemm canal. The light pipe guide the right or groin tract of Schlemm canal and prevent inadvertent entry in anterior chamber. Same procedure is being performed in another site. After confirming the right tract of Schlemm canal, Harm's trabeculotome is being introduced to complete the trabeculotomy. Same procedure is being performed in another site. To conclude, in conventional trabeculotomy, accurate localization of Schlemm canal is the key to successful surgery. 25 gauge light pipe can be used to know the right tract of Schlemm canal before introducing Harm's trabeculotome. Thank you for patience hearing.
I have one question. So after you put this light pipe in the Schlemm's canal, do you confirm it by doing gonioscopy or something, whether it is correctly in the Schlemm's canal or no?
Actually, it is a case of palmatal glaucoma. There is a hazy cornea. It is not possible to visualize the angle of by the gonioscopy.
So how is it helping you? Because
By
you are
measuring-
anyway going to put that goniotome, in the same place you are putting the light pipe also. And second thing is that the light pipe is entirely exposed, so the entire length of the light pipe will be illuminated because you have removed the cover. It's not just the tip; the entire thing will be illuminated. So I think it will be a bit of a difficulty unless you see from inside.
By monitoring the light pipe, the tip of light pipe is more illuminated, and by monitoring the distance between the limbus and by observing there is no illumination of anterior chamber, because we can advantageously enter the anterior chamber by while doing the trabeculotomy with the Harm's trabeculotome. So this will guide there is no illumination of anterior chamber. In this way, we can just guide before introducing the trabeculotome.
Bhavesh, you are entering a meshwork. So in a meshwork, when you are introducing Schlemm's canal, but the canal also has septas and all, which is passing, a optical fiber which doesn't have strength, it doesn't have the tensile strength, it has got a brittle strength. So don't you think sometimes you may not be able to really create that, because here it is a metallic thing what you are using, where you know that it is, but in a optical fiber, I'm not convinced that we can have a optical fiber, because we know how fragile that fiber is.
There is already illuminated optical fiber in the market, but not available in the India. They introduced the 360 degree.
But does it have some metallic or something coating? Because you do need some strength to that fiber.
No, there is already
Okay,
available.
done. If it is available in the market, nothing like it.
But not available in India. This is the one type of jugaad technique of.
Jugaad technique. Good, great jugaad.
Very nice.
Thank you so much.
Dr. Ganesh, have you come? He's arrived. So Dr.
Bhavana,
Ganesh,
please give a certificate.
though late, please
Dr.
come.
Bhavana.
Procuring a 25 gauge light pipe and the this itself is costly.
Will be costly. Thank you so much.
I don't think they are manufactured separately.
Thank you. Good morning, and good morning to all the judges and delegates here. First, I'd like to thank APO AIOS for giving me this opportunity to speak to you on the tunnel and track technique of GDD implantation. No financial disclosure with respect to this presentation. The tunnel, the technique of tunnel and track tube placement, we have been following for quite some time, and it entails making a scleral tunnel about 4 millimeter away from the limbus, so that this tube is snugly fit inside the tunnel, So you create two grooves on the sclera, use a crescent blade to make a tunnel, and the tunnel is created by the full thickness of the tunnel being created by this crescent. And after that, what you do is use a 23 gauge needle, introduce that needle into the anterior chamber or into the sulcus, as the case may be, and create the track technique. So you have a distal track and a proximal tunnel. The advantage is that the whole length of the tube is covered, almost 8 millimeters of it is covered, so very less chances of complications in terms of tube exposure or tube retraction or tube misplacement. So this is a video which just shows you how to create the tunnel and track technique. So this, you would notice this is a limbus-based congenital flap, so it's easy to access the site where you're going to implant the plate of the GDD. And once you have done that, you don't want the tube to be interfering with your tunnel creation. So you put it between the sclera and the plate. So it goes and hides there till you create the tunnel. And this is the first groove being made proximally, and the second one made distally from you. And once you made the groove, it's partial thickness. The 15 number blade helps you to do that because the bevel of the 15 number blade is 1 millimeter. If you enter half of it, if you enter half of it, then so this is the so you can see the tube is not coming in the way of creating the tunnel. And you use the 15 number blade again on the opposite side as you are, because you don't want to enter into the track area. So as you approach the tunnel, you use the 15 number blade to lift up the crescent, which is shown here in this video. You get back the 15 number blade in your left hand, and then once it touches, you lift up the tunnel, the crescent, and you create a tunnel through which the tube can be placed. And you can do that inferiorly also, infranasally if you're wanting to place, or infratemporally you want to place the GDD. Again, the principles are the same. You make two grooves. And here in the inferior, it's more easily done because you are going from the proximal to the distal again. So you can do it very easily and introduce the tube through that site. So you have a tunnel. You don't have to use a patch graft for this because it's already intrascleral. And the tube is a non-collapsible lumen. So unless it gets really tightened by a suture, it won't really collapse. The lumen remains, it may distort, but the lumen doesn't collapse. So that's the beauty of using such silicon-based tube devices. They don't collapse of their own unless external compression is applied to that. So the sclera can accommodate the tube and the flow can occur. So this is a patient who had a trap done, and we use the same technique. You can see there is no it's all under the sclera. You don't see any increase in profile of the tube to cause complications. And gonioscopically, you can identify the tube being in the very close to the PI area of the previous trap, and it's very close to the ciliary processes. And this again a patient with eye syndrome who has got a well-dilated pupil, and you can see that tube is having very low profile, and it's behind the iris. It's coming into the sulcus, into the anterior chamber, which makes it easily visible. And the blue suture which you see is a ripcord suture, which is placed in the lumen to reduce the chance of hypotony. So we did a small study also. Is it time's up? And you can see that between the patch graft and the tunnel and track technique, there is very less difference in the intraocular pressure control as well as the medications. Thank you very much for patient listening.
Thank you, Dr. Ganesh. It was a very good idea to take help of the BP knife to come out on the other side of the crescent knife. But the only problem is when you make such a long tunnel, by the edge of this crescent knife may cut your scleral tunnel in the sides.
True, yeah, that is true. So we scleral tunnel everybody is familiar with. We use it for SICS, and avoiding patch graft. Another important thing is we can avoid transmitting prion diseases, because prion diseases are something which are really serious, but it's not very commonly reported. But that's a theoretical risk of transmitting when you use a patch graft.
The tube of the GDD enters the anterior chamber at the distal end of the tunnel, is it?
Yes, madam. So we make a track after that. We use a 23 gauge needle and make a track to enter into the anterior chamber. So that allows you to either be in the anterior chamber or into the sulcus.
So these cases which require GDDs are advanced glaucomas.
Correct, madam.
And would you believe that the sclera remains in this structure and this configuration to get a tunnel made, and the you know, there's thinned
Absolutely,
out
because
sclera
we
and
have-
staphylomas are there most of the time, and scleras are already
very
compromised.
Yeah, by the time the staphylomas form,
Yeah.
they are actually end-stage disease. We
So,
don't do these procedures for them.
yeah.
We do it for eyes which have good vision. So those scleras are always 1 millimeter thick. Sclera
So-
cannot change anatomically, it's always 1 millimeter. So that's the advantage of using this technique. If you have that, if you happen to have a site of sclera, then you have to avoid it. Then you use a patch graft over that. But we have not experienced, and we don't operate such cases anyway. By the time they have staphylomas, they're already blind. So we do some other procedure for them, like a cryotherapy or a cyclodiode or something like that.
Okay, but we do believe that in advanced glaucomas you have changes over the sclera to
Definitely.
get this kind of tunnel and this kind
Yeah,
of
and the
structures. in
areas
this.
where they become weak are near the muscles. So you are operating between the muscles, so that gives you a leeway of putting it. We have cases like that, but we have taken it through the between the staphylomas as well.
Okay, can you ask Binda to please give a certificate to him? Certificate, sir. No, no, it's not. Yeah, Ganesh. Do I see Harshal here? Yeah, please come. Harshal is going to talk to us about vitreous lavage in upright position. It's another outdoor procedure.
Hello everyone, I am Dr. Harshal and I am going to discuss about a vitreous lavage. It's a new tech, it's a already described technique in a new way. Let's start.
Hello everyone. I'll be presenting an exciting and innovative approach in ophthalmic surgery, an upright vitreous lavage, an innovative topical air fluid exchange. I have no financial interest. Coming to background, a 38 years old gentleman presented with diminution of vision in right eye post, pars plana vitrectomy, with air tamponade secondary to vitreous hemorrhage associated with type 1 proliferative diabetic retinopathy. After observation for 1 month, he was posted in OT for vitreous lavage, but in innovative way. Procedure involved: a single 5 ml syringe with 30 G needle is injected at 6 o'clock position under topical anesthesia, under strict aseptic precaution. Gradually, air is injected inside the globe and allow the vitreous fluid to come outside simultaneously on the same syringe. Here's how it works. Improved gravity. Assistance. Blood, debris, and fluid are naturally directed downwards due to gravity, improving clearance and minimizing turbulence in the vitreous cavity, also enhanced visualization by reducing pooling of blood. Globe pressure is checked throughout the procedure. A 3.5 ml vitreous fluid is aspirated from globe, and while same amount of air is replaced by it. Take-home message: an upright vitreous lavage. Topical air fluid exchange for vitreous hemorrhage represents a promising innovation in ophthalmic surgery. It offers better visualization and recovery without going for revitrectomy. Thank you.
Just a question. When you're doing this, it is under microscope, you're seeing the retina, you're seeing something inside the eye?
No sir, it's...
because then it becomes a blind procedure.
Yeah sir, but B scan we do, that's why we just check.
No, agreed.
Yeah.
B scan is just pre-op, you're doing it.
Yes.
But when you're doing the procedure, what you're doing is you're injecting,
Yeah.
because your amount of injection and amount of egress,
Yeah.
and without watching the retina, without watching something happening, if this needle or if the injection is going somewhere, I think you have to be a little careful about it. Because though this is an OPD procedure, we do it for post-vitrectomy hemorrhages.
Yes.
But post-vitrectomy hemorrhage is like we just get in and we just
Yeah sir, generally we as a surgeon we observe at least for 1 month. If it is not resolved, then we plan this thing. Yeah, actually it is a blind procedure, but post injection we used to do B scan to see the status of gas and the retina also.
Can you think of a dual bore cannula where you have the injection going through one and the blood coming out through another,
Yeah,
so that you can maintain the pressure, because here you're touching and finding out how much is the pressure.
Yes sir.
Now your tactile judgment is not always perfect.
Yes, sir.
These are critical patients. Sometimes it may cause a lot of venous issues.
Yes, sir. But yes, sir.
So did you come across any complication while doing, because this, as sir mentioned, it's a blind procedure. So
Sir, till
did you
now
get
I
any
have,
complication in
I
any
have
of
done
the cases?
around 12 patients, and this was 3 patient was fake kick. Till now, nothing, sir. But I hope in future also not, sir. Till now, I didn't get anything.
Actually, there is a possibility.
Yeah, possibility
It's
is there,
easier to
yes.
do a vitreous lavage, which will take around 5 minutes to do.
Yes, sir. Just wanted to reduce the one more surgery. That's why we done. But yeah, it's definitely the risk-benefit ratio is there.
So
Thank you.
I want just one question. So this is a very well-known technique. This
Yeah.
I learned in my fellowship 30 years ago.
Yeah.
So it's not a novel technique.
Yeah.
And moreover, when you do it in a phakic patient,
Yes.
there is a chance that you can cause lens damage. Second thing is, when your needle is pushed into the vitreous cavity so much inside, you will have some residual fluid in the inferior area. So you need to withdraw the needle as the fluid goes down.
Ma'am, at the last step, I just need to retract little bit so that the residual fluid will come. That's what I do at the last.
Thank you so
Thank
much,
you.
Harshal.
Thank you, sir.
I, at this stage, welcome Anaga here, and I'll request her to give a certificate to you. It's your privilege. And Shruti Devi, do I see her here? Yeah, please come. She's the last speaker. After that, house is open.
Hello everyone, this is Dr. Shruti and my presentation is on iridodialysis repair, bridging the iris, precision repair and restored vision. So as we know, iridodialysis repair is a complex procedure and requires special instruments and good surgical expertise. So here we describe a simple suture technique to repair an iatrogenic iridodialysis that occurred during a small incision cataract surgery. It is a very simple technique and involves minimal tissue handling. So the aim was to provide a functional and a cosmetic result in the same sitting as a primary procedure with the common available instruments. The incidence of iridodialysis due to SICS stands at 0.2%. Intervention may not be required if the dialysis is small, but large and asymptomatic dialysis requires surgery. The superior iridodialysis involving 10 o'clock to 2 o'clock position are less symptomatic as it's covered by the upper eyelid, whereas the temporal, inferior and large iridodialysis are symptomatic. So numerous techniques have been described, most of them are being technically challenging. So here we describe a simplified approach of iridodialysis repair using 10-0 ethylon suture and basic instruments used for a conventional cataract surgery with a favorable outcome. So this slide depicts the pre-op image where this is a figure 1A which shows the pre-op photograph showing an inferior iridodialysis from 4 o'clock to 8 o'clock position and the prolapsed iris which is seen through the main wound. And figure 1B shows the pre-op photograph after depositing the iris from the main wound. And this is the post-op image where the iridodialysis is corrected and formation of fairly round pupil is noted centrally. So this is the schematic representation of the surgical technique. So as you can see, this is the pre-op photograph where the iris is prolapsed with sclerocorneal tunnel and iridodialysis is noted inferiorly. And after depositing the iris from the main section, an inferior conjunctival peritomy is done where the suture is passed from the sclera and taken into the corresponding iris inferiorly and the suture is exteriorized through the cornea. And suture knots are rotated into the angle of the anterior chamber to approximate the iris towards the insertion. We could not capture the intra-op video. This is a demonstration model where the suture is passed from the sclera through the corresponding edges of the iris inferiorly. The suture is exteriorized through the cornea. The suture knots are tied individually in 3' true fashion. So the advantages of this technique is it can be performed with available instruments used for conventional cataract surgery, and stability of the anterior chamber is also maintained and involves minimal tissue handling. However, the disadvantage is that the exteriorized suture on the cornea can cause irritation and pose a risk for infection. To address this, BCL application is advised and closely monitored, and the patient is put on topical antibiotic eye drops along with regular post-op medications. So to conclude, this is a simple suture technique which would come in handy in urgent situations and requires less expertise and minimal common surgical instruments. Thank you for giving me this opportunity.
Can you please explain when you suture the iris, will it not get anteriorly displaced and get stuck to the peripheral cornea if you are passing, and also a corneal astigmatism also might be there, I think. Conventionally, we pass the suture through the sclera with a flap and then tie the iris, whatever the part of the iris, to the sclera where it fixes into the sulcus. Now here you are taking it in the cornea, so your iris is getting pulled anteriorly. So are there any complications that you can think of that can arise in this?
We have employed this technique in 2 surgeries, ma'am. We haven't encountered any such complication post the procedure.
Another thing is you're putting a BCL, but you can't keep the BCL for a long time.
Yes, ma'am. After
So
trimming the suture, we'll remove the BCL, ma'am.
yeah, but the original technique where you actually approximate it to the angle is itself a very, you can just keep a 90 prolene in the OT. So it's just a straight angle and you can take it. And that is not exteriorized, so the risk of infection and irritation is much less. So in this case, even though you're using a 10-0 ethylone, but you're passing it through the cornea, peripheral anterior synechiae, exposure to outside. By taking a peritomy, you're not achieving much because anyways it is exposed on the corneal side. How much actually it's going to impact other than using a 10-0 ethylone instead of a 9-0 prolene? Yeah.
We are just finishing in time. We have some recognition of the chairpersons. First, before your Shruti. Shruti, please. Good job.
We recognize and appreciate the panelists to be with us, and first of all, Dr. Prashant Agnihotri, this is a certificate of appreciation for you, sir.
Thank you so much. Always. Photo. We'll come.